And without further ado, I would like to introduce my very good friend, colleague, and prior trainee, Dr. Darshan Doshi, who leads the complex PCI and CTO program at Mass General to educate us about update in CTO PCI, what we've learned, and where we're going. Darshan, the podium is yours.
Dimitri, thank you so much for that kind introduction. I have the distinguished pleasure of talking about the salient CTO PCI literature. It's unfortunately a 10-minute talk, so it's hard to encapsulate the true breadth and depth of what we've actually learned and where we need to go in that time frame. But what I will do is highlight some of the important studies from the past year or so, and then sort of touch upon areas where we still don't have data and need to further investigate. These are my disclosures. So we know that the two aspects that really make CTO PCI unique compared to traditional angioplasty is the fact that one, CTO operators must know how to go retrograde, and two, how to leverage the subintimal space to complete CTO PCI. And so the data around retrograde CTO PCI and then also subintimal stenting has been marred with some controversy. So I want to highlight some studies specifically focused on that first. So the first study I'm going to talk about comes from Manos Brolakis and his team. It comes from the Progress CTO registry, where they looked at around 4,000 patients that underwent retrograde CTO PCI and compared them to antegrade only CTO PCI. And what they found, which one would expect, is the fact that in order to complete higher JCTO CTOs, more retrograde techniques were required. But when we performed retrograde techniques compared to antegrade only techniques, the procedure time was longer, there was more contrast volume given, there was more air karma radiation, and the fluoroscopy time was greater as well. And then when you looked at clinical outcomes, specifically things like procedural success, it was lower with retrograde cases. In-hospital MACE events were also higher, death was higher, acute myocardial infarction was higher, the need for emergent reintervention was higher, the need for pericardiocentesis was higher, driven by greater perforation in retrograde cases as well. Now, the issue with Progress CTO was that it was a self-reported registry with no core lab. In contrast, the Open CTO study took 1,000 consecutive patients undergoing CTO PCI at large volume centers and had a core lab that basically adjudicated the outcomes. And so an analysis led by Sanjog Kaura and with Dimitri looked at retrograde CTO PCI compared to antegrade only approaches from the Open CTO registry. And just like Manos's study, essentially those undergoing retrograde cases had a higher JCTO score, nearly a point higher. And then they also had worsened in-hospital outcomes. So technical success was lower with retrograde, procedural success was lower with retrograde, MACE rates were higher, the clinical hematomas, pericardial effusion, pericardial tamponade, and cardiogenic shock were much higher with retrograde approaches. And so when you look at the MACE rates, and so the dotted line here, any retrograde approach compared to antegrade only, and the MACE rates are higher for retrograde approaches. So the survival is lower here. But the interesting thing that Sanjog did was basically he excluded those patients that had an issue in hospital and looked at only those that were able to be discharged home. And what he found essentially is the fact that MACE rates, when he did a landmark analysis, were exactly the same. So what this kind of points to is the fact that you take an upfront hit with the procedure, but if you have no issues from the actual procedure itself in-house, then subsequently your outcomes are very comparable to those as it pertains to MACE compared to those that are going antegrade only approaches. The other aspect is looking at the quality of life. So what we do know definitively is that CTO PCI does improve quality of life. Unclear about a mortality benefit, but a quality of life benefit cannot be argued. And so here, what you can see is that patients that require retrograde techniques actually have worse Seattle Angina Questionnaire scores. So they have more physical limitation, more angina frequency, worse quality of life, and ultimately their summary score is lower. However, after undergoing CTO PCI, the change in baseline is the same whether you went a retrograde or an antegrade approach, meaning that both approaches really improve quality of life. Now, not to beat a dead horse, but Megali et al. Basically did a meta-analysis of 12 studies. And again, it highlights the same sort of thematic points that the other two studies showed. One, that retrograde requiring procedures had lesions that were longer, more complex. The procedure was also longer, requiring more contrast and more fluoroscopy. In-hospital events were also higher. But interestingly, one of the things that they found was that the long-term outcome at 48 months in patients that underwent retrograde CTO PCI, they had a higher rate of myocardial infarction. They also had higher target lesion revascularization and also target vessel revascularization, but similar risk of long-term mortality. So ultimately, all in all, it basically shows that retrograde CTO PCI is needed to complete CTO PCI, but it is associated with greater in-hospital events and potentially with worse and long-term outcomes. Now, shifting topics a little bit, looking at dissection reentry techniques. So one of the main concerns that a lot of operators had was, if I stent the subintimal space, are the outcomes going to be similar to those if I am able to stent into the true lumen throughout the entire CTO? And so there's been controversy back and forth. And then last year, Simon Walsh and James Spratt performed a study called the Consistent CTO study. Now, this study took approximately 210 patients and then divided half of them in patients that underwent dissection reentry techniques called DART, either antegrade or retrograde, and then those that required no dissection reentry. And then they confirmed their crossing pattern via IVUS. This was adjudicated by a core lab. But when they asked the actual performing clinicians to say, how do you think you crossed, 1 in 6 was wrong in the way they crossed. And then these patients were followed up 1 year with both OCT as well as angiography. And what they found was that the lesion length was obviously longer in those that required dissection reentry techniques. They were more likely to have had prior CABG. They were nearly a full point higher in their JCTO score. The stent length was also longer. But the MACE rate at 2 years was exactly the same, kind of, again, sort of pointing to the fact that whether you use dissection reentry techniques or not, that the outcomes are fairly similar, but that for more complex lesions that you really need to leverage dissection reentry. Now, one of the things that we know that has been sort of dogma is that you really need support and you need large catheters in order to do your CTO PCI. Certainly, when I trained, it was not uncommon to use 2 8 French bifemoral sheaths. But Canvas and colleagues from 5 different European centers performed a retrospective analysis where they looked at CTO PCI procedures that were fully transwrist. So they used either the radial or the ulnar in one hand, in 2 hands, or a combination, compared to a conventional transfemoral approach. And what they found was that, again, this was a retrospective analysis, not a RCT. What they found is that for low, medium, intermediate JCTO scores, that the utilization of the conventional and the fully transverse approach was statistically no different. And their primary endpoint was a combination of vascular complications and major bleeding. And this was vastly in favor of the fully transverse approach, that you had a lower primary endpoint. But this was not driven by major bleeding, but mainly by vascular complication. And when you looked at vascular complications, it was predominantly just a local hematoma. So again, potentially there may be some benefit to using a transwrist approach if possible, but it's really driven by vascular complications and specifically local hematomas. In the same vein, colleagues from a center in the Netherlands said, hey, if the transwrist is potentially better, what if we use, quote unquote, a minimalistic hybrid algorithm? And so in this scenario, what they did was anyone that has a JCTO score of 1 or less, they then only used a single 6 French transradial for AWE. If they failed and there were interventional collaterals, then they would try to cross the collaterals, and if they were successful, then they would put a second transradial guide in to perform either retrograde wire escalation or reverse cart. But if there were no interventional collaterals, then they would upsize to a 7 and potentially then put a 6 French transradial for contralateral injections, or upsize to an 8 French from the groin. And here they found again that they had acceptable complication rates with the minimalistic approach. Now, one of the things that we know with CTO PCI is that these cases tend to be longer, require more radiation, and can potentially lead to orthopedic injuries in the future. And so the colleagues from Mid-America Heart Institute attempted to perform CTO PCI using the Corindus GRX robotic system. So what they did was they took half of their patients in this analysis, and they underwent CTO PCI via the conventional route. And then the other half, what they did was they crossed manually, and then they would then allow the robot to complete the rest of the procedure. And what they found was that when they used the robot, the fluoroscopy time was lower. The radiation was obviously lower. The cockpit time, which is the time that you're out of lead, was higher. And the major adverse events were no different. There were no deaths in either, so there was nothing else there. So this sort of hints to the fact that maybe using a robotic system, particularly after you've crossed, may be advantageous to operators in the long term. Now, one of the things that has been frequently cited is collaterals. And so, it's not uncommon for us to hear that, this person has a CTO, but they have robust collaterals to the CTO. So they really don't need an intervention there. And so in this study, what was done is that the CTOs were crossed, and then after they were crossed, an IFR wire was placed. This kind of recapitulates a lot of what Gerald Werner did with FFR. And what they found was that almost every CTO that was crossed was grossly ischemic. The average IFR was 0.33. We know that a cut point of 0.89 is used to intervene. So this was grossly ischemic, despite the fact there were collaterals. And that almost all of the patients that underwent CTO PCI had an improvement in their IFR to 0.93. And those that were still below the cut point, the vast majority, it was a focal lesion that you could treat and then get above that threshold. Now, the last study I want to talk about is specifically regarding the use of antegrade fenestration and reentry. This is a technique that Dr. Juan Russo will be going over shortly, but essentially what it entails is that if you have a wire in the subintimal space and you're not able to reenter, what you can do is use a balloon on that same wire in the subintimal space and then use a second system with a microcatheter and a polymer jacketed wire. Inflate the balloon on the original wire to create fenestrations from the subintimal space into the true lumen. And in this registry, Lorenzo Azzolini and colleagues basically found that that they were able to perform AFR and were successful nearly 2/3 of the time. And so they used the hybrid algorithm, and they say that potentially AFR has a role when you're trying to do ADR and you have stingray failure, or a stingray is not available, or if you're trying to do RDR and you fail, then AFR may potentially fall within this paradigm. Now, in the interest of time, I'll stop there. But one of the things that you see that is still missing is a definitive RCT in the favor of hard endpoints. So again, there's quality of life improvements. There are other secondary endpoints that may potentially be beneficial by doing CTO PCI, but we don't have one that shows a true mortality benefit as of yet. So ischemia CTO is an ongoing RCT. Noble CTO is another ongoing RCT. And so they will sort of hopefully kind of guide us further. Now, I showed you that retrograde CTO PCI is associated with higher MACE and complication rates. So we still need additional strategies to mitigate those rates. We also need greater innovation in both techniques and tools. So there's obviously a great deal of research that's going on right now for new devices. Some of the devices that we use readily today weren't even available when I did my fellowship in CTO PCI, and it wasn't even that long ago. So the field is continually evolving. And then ultimately, obviously everyone listening today is interested in CTO PCI, but how do we institute best practices around training? How do we do proctorships appropriately? How do we get remote CTO PCI training out to others? These are still questions that need to be answered. And, CTO PCI as a field, since it started, decades ago, is starting to become much and more refined, but we're still scratching the surface of what it has to offer. And again, it's people like the people on this panel, you out there, that are ultimately going to be able to sort of drive the field forward. Thank you so much for your time. I'll stop right there.
Thank you, Darshan. That was a great talk. There's obviously a reason why you're a leader at MGH and a great academician and a great operator. Always proud of you.